Hello, fellow EMS providers. Thank you for taking a few minutes to learn about self-triage and triage ribbon kits. This training opportunity has been brought to you by your partners at the South Central Wisconsin Health Emergency Readiness Coalition and the South Central Regional Trauma Advisory Council, or SCRTAC. When responding to and managing a multi-victim incident, or MVI, it's imperative that all participants are operating on the same playing field. All players must be unified in their communications and their operations. Not only will this unified approach save time and lives, it will make our scenes safer. We have a few really important topics that we will focus on in this training. Here's today's checklist. As EMS providers, we are well versed and prepared for the standard day-to-day operations. Our normal responses to patients with fall-related injuries, chest pains, or difficulty breathing are adequately managed by our EMS system. We generally can handle the call volume and the needs of the patient with our normal daily EMS operations. Our local hospitals are also well versed and prepared for the standard day-to-day operations. They all provide excellent care to the wide variety of patient presentations that arrive by EMS and private vehicle. They too can generally handle the traditional daily call volume and the needs of the patients they see. And from a regional standpoint, we are also well prepared to handle the daily challenges that present, the things that might not be able to be managed at the local level or by local resources. We have excellent ALS to intercept practices, great air medical resources, and top-notch specialty hospital resources, such as STEMI, stroke, trauma, and burn centers. Again, we as a region are quite prepared to handle the call volume and the needs of the patients. But when an MVI occurs, things change. Things change for EMS, for the local hospital, and for the region. You have heard me use the acronym MVI. An MVI is a multi-victim incident and signifies that we must make some decisions at our scene, prioritizing patient care based on the needs of the patients. An MCI, on the other hand, is a mass casualty incident and results when the number of patients exceeds the resources of the primary responding agency. So, an MVI with 4 patients that occurs in a small rural town may trigger an MCI. But an MVI with 8 patients in a large urban city may readily be handled by the primary responding EMS agency. In either case, an MVI exists, and we must change our mindset in managing the scene and prioritizing the patients for care and transport. The response and overall approach to managing the MVI is very different from day-to-day operations. Responders must be able to identify that an MVI exists and must change hats by following a totally different set of rules. Whether you are dealing with a 3-victim MBC or a 45-victim bleacher collapse, the underlying mission must be the same. We must do what is best for the greatest number of patients in the least amount of time and with limited resources in order to save the most lives. As EMS providers, we are a very important piece of the MVI success puzzle. We are often the first link of the patient care chain. As the first chain link, we have the hugely important task of performing triage. It is triage that kickstarts the two-way communication highway between the scene and other responders, as well as local hospitals and regional hospitals. We are now going to dive into triage. While triage is likely not a new topic in your EMS career, it's likely one that could use some improvement, or at least a refresher. Think about it. When was the last time, if ever, you used a formal triage system in the field? And how often do you train with a triage system at your EMS agency? Once a year, at most, is common. Triage is a crucial objective for initial EMS responders. Other than scene size up, triage is what truly dictates all other MVI EMS operations and communications. Triage will give us insight as to the number of patients and the severity of their injuries, the resources needed on scene and resources needed for transport. Furthermore, it can help facilitate regional communications and preparations, which will guide transport destination determination. When talking about triage, it all comes down to muck. No, not the slimy muck at the bottom of a shallow pond, but MUCC. In 2012, the Federal Interagency Committee on EMS, comprised of researchers and medical professionals from around the nation, convened to evaluate triage systems. How well did each system work? What were their components? Were they based on science? Or were they based on current best practice? And were they able to expand to meet the needs of an incident? These are just a few of the questions they asked. The panel identified 24 criteria that they felt triage systems should contain, and they termed these Model Uniform Core Criteria, or MUCC, MUC. Unfortunately, no triage system at the time met all 24 of these criteria. So this same committee worked and developed a triage system that would meet all 24 criteria, and SCRTAC Triage is the system they developed. So what does this mean for you and your EMS agency? Well, we hope you and your service will join in on the transition to SCRTAC. Though not mandatory at this time, we hope you will see the importance of using the best triage tool for the job. For having all EMS providers trained and operational with SCRTAC Triage will greatly strengthen our trauma system. The acronym SALT stands for Sort, Assess, Life-Saving Interventions, and Treatment Transport. Now, let's break down each section. The first step in SALT is sort. We must sort our patients into groups based on their ability to move and communicate. It makes sense that patients that are able to easily move from one place to another are likely less sick or injured than those that cannot, right? And it makes sense that those that cannot move on their own or communicate are likely the sickest, right? Well, this global sorting of SALT triage places patients into 3 different groups. The first group is those that can follow your instruction to move to your designated casualty collection point. Again, these should be the least sick or least injured. The second group is those that cannot move to your designated casualty collection point, but are able to communicate to you by waving. They may have significant injuries, but they are alert enough to follow your instructions, to wave, and can follow simple commands. Now, the third group is those that do not move to the collection point and do not follow your simple commands to wave. They show no purposeful movement. These patients are likely your sickest. Therefore, we're going to assess them first. To review the global sorting of SALT triage, we have the walkers, the wavers, and the unresponsive. These are the 3 groups that our sorting has created. We will now assess these groups in reverse order, with the unresponsive, or likely the 6th group, assessed first, then the wavers, then the walkers. Before we dive into the SALT assessment, we need to emphasize an important practice. Anytime you find a life-threatening injury during your assessment, one that you can rapidly perform a life-saving intervention, you should perform that intervention, but only if you have the resources to do so. For example, you may quickly place a tourniquet, instruct a bystander to hold direct pressure, or even open an airway with a head tilt chin lift. But what you must not do is provide your normal day-to-day EMS care for a single patient. You must move on. Remember, the completion of triage is what determines the resource needs for EMS operations at your scene. We need the triage results ASAP. You must move on. In SALT triage, any patient that is not spontaneously breathing after opening the airway is marked dead with a black ribbon. There are no rescue breaths delivered to adults. With peds, however, you may consider giving up to 2 rescue breaths. The SALT assessment is simple and can be performed in as little as 15 seconds. We'll look at the 4 assessment components. First, obey commands makes purposeful movement. Does the patient follow simple instructions? Simple tasks such as open your eyes or blink 3 times should be used, not is your patient alert and oriented times 4 or who is the president? Do they make purposeful and appropriate movements such as to painful stimuli? Has a peripheral pulse? Can you feel a radial pulse or a posterior tibial pulse? This is just looking for presence, not the strength, rate, or regularity. Is not in respiratory distress. You're an EMS professional. You know when your patient is in distress versus crying or panicking. Consider the rate, the depth, and effort of the breathing. And major bleeding is controlled. Does the patient have any major external bleeding? If so, have you been able to control it with direct pressure, tourniquet, or other means? If the answer to all these questions is yes, move to the right in the algorithm. These victims will be tagged yellow or green. If the answer to any of these questions is no, move down in the algorithm. These victims will be tagged gray or red. If you answered no to any of the previous criteria, your patient is critically sick or injured. The next step separates salt triage from the other triage systems. You must now determine if you think this patient will survive. Given the patient's presentation, the resources available to you at the scene, the resources needed for transport, such as time or advanced life support, and the resources available at the closest hospital, do you expect this patient to survive the injuries or illness? If yes, you do think they will survive, you mark the patient as immediate with a red ribbon. If no, you do not think they will survive, given their presentation and resources readily available, you should mark them as expectant with a gray ribbon. Let's think about this for a minute. If a patient has been assessed as having a major traumatic injury, and given the current available resources is not expected to survive, is it appropriate to allocate significant resources to this patient? Should they be prioritized for transport and prioritized at the receiving hospitals ahead of those that have a potentially survivable injury? In salt triage, living patients that are not likely to survive are categorized as expectant. They are marked with a gray ribbon and left to be reassessed and treated at a later time when other priority patients have been managed. This is another unique difference from START triage that helps address some ethical challenges with triage, as well as address resource conservation, doing the greatest good for the greatest number of people in the least amount of time with limited resources. With the immediate, expectant, and dead patients marked with ribbons, you must now address the remaining patients. Now again, as a medical professional, you know what a significant injury is and you know what a minor injury is. Put on your thinking cap. What type of injury does the patient have? If it is a significant injury, mark the patient as delayed with a yellow ribbon. And if the injury is minor, mark the patient as minimal with a green ribbon. Here are the SALT triage categories. You will indicate the patient's category by affixing an appropriate colored ribbon to the patient. You may ask, what about triage tags? Well, triage ribbons have proven to be much faster and much easier to apply compared to a triage tag. In addition, they prevent the EMS provider from wasting valuable triage time collecting unnecessary patient information. Patients may be given triage tags when they reach the treatment area or during transport, where additional patient info can be documented. And here is the SCRTAC Salt Triage Ribbon Dispensing Triage Kit. The ribbon kit is designed to wear as a fanny pack. The spools of ribbon must be kept horizontal to properly dispense the ribbon. Please do not attempt to wear the kit as a shoulder sling, as the ribbons will slide off the spools, tangle, and will not dispense. To dispense ribbon from the kit, pull the appropriate colored ribbon from the kit straight out in front of you. Make sure you pull enough ribbon, have enough to tie and have ends readily visible. An arm's length is a quick way to measure. Make sure you break the ribbon at the kit with enough of a tail remaining to make it easy to pull for the next patient of that color, about 6 inches minimum. When possible, place the ribbon on an upper extremity at the wrist. If the upper extremities are not available, the secondary location is the lower extremities at the ankle. Tie a simple granny knot or a square knot, but not a bow tie that could come loose. After placing a ribbon on a patient, use the affixed marker to indicate the patient's triage level. Note, there are separate columns for adult and pediatric patients. This documentation will assist with patient counts, resource requests, and Regional Medical Coordination Center communications. When you communicate your triage results to the triage group supervisor, report on the number of adult and pediatric patients and their associated color category counts. For example,
triage group supervisor from triage team A, we have the following triage counts. For pediatric patients, we have 3 red, 2 yellow, and 5 green. For adult patients, we have 4 red, 3 yellow, 6 green, and 1 gray.
Once you have reported on those patients, circle the patient tally marks on your tally sheet. This will prevent number confusion if you are assigned to perform triage in a new area, which is common at MCIs. You need to know what patients you have already reported and which ones you have not. Circle them rather than cross them out, as your tally sheets may be needed for total triage counts later in the incident. Patient movement to treatment areas is not performed during triage. The one exception to this is the walkers being instructed to move to a casualty collection point on their own. Patient movement is tasked through the incident command system and should include other personnel. Triage teams may be reassigned to patient movement after initial triage is complete. During patient movement operations, immediate or red patients should be moved first, then yellow, then gray. If at your scene a formal treatment area has been established, when the patient arrives at the treatment area, a number of things should take place. Upon reaching the treatment area, the patient should undergo secondary triage. Has the patient's condition changed since the initial triage? After the secondary triage is completed, a formal triage tag can be applied. Now, why the tag, you ask? The triage tag can now be used to document ongoing assessments and interventions. And it's also the start of patient tracking, where patient demographics can be documented, such as name and date of birth. The scannable barcodes allow for electronic patient tracking, both at the scene and at the hospital. We use the ribbons during initial triage for their speed and simplicity. Again, we do not want documentation on tags to take place during initial triage. Triage must be performed very quickly so that a patient count, including the severity of injuries, can be obtained and adequate resources can be secured. Now, let's talk about the expectant or gray patients. When a patient that was designated as expectant reaches the treatment area, it means that all of the immediate or red patients and the delayed or yellow patients have already been moved to the treatment area and are already being managed. When the expectant patient arrives at the treatment area, they also undergo secondary triage. Did their condition change? If so, they are moved to the appropriate treatment color area and tagged with a formal triage tag of the appropriate color. But if they remain expectant, they are now tagged red or immediate. Remember, the other red and yellow patients have already been addressed and are being prioritized. The expectant patient can now have remaining available resources allocated to their management. And if the patient is dead upon the secondary triage assessment, the patient is tagged as being dead or black and is moved to a deceased collection area out of the way of the treatment and transportation operations. We have completed the self-triage and triage ribbon kit portion of this training. We thank you for your time and attention to this new initiative, and we are confident that it will strengthen your capabilities and operations at MVI and MCI incidents. But to be effective, we need each of you to train with the equipment and on the lessons provided. Remember, triage is one of those things that does not get used frequently, but when it's needed, must be performed accurately and without hesitation. We recommend triage training and review at least 2 times per year. We are now going to transition to a new and exciting tool that can assist you in managing a multi-victim incident. Welcome to the Regional Medical Coordination Center, or RMCC. Now here's the scenario. You have been assigned to the role of Transportation Group Supervisor at a multi-victim incident. You have 9 patients of varying triage levels and ages. You must direct the responding ambulances to transport these patients to hospitals. So, how do you determine where to have these patients transported? How many patients can each hospital in your area accept? How busy are these hospitals already? How do you know? How do you find out? How long will that take? Do you call each hospital individually? Who has time for that? For years, we handled MVIs by either overloading the closest hospital or by calling each individual hospital to determine their capabilities, a practice that took way too long. This wasn't best practice for EMS, for the hospitals or the patients. The goal of RMCC is to give EMS a single point of contact to learn what all the hospitals can manage. Give the hospitals awareness early that a situation is happening, and therefore give patients the best possible outcomes. Using RMCC will help prevent overwhelming any one hospital. It will create region-wide situational awareness that will prompt regional preparations, and it will initiate tracking of patients that are transported. Here's how RMCC can help you manage your incidents and patient transports. First, EMS activates the RMCC. The RMCC, in turn, activates a regional alert that notifies regional hospitals of the incident and orders the hospitals to report their capability to accept red, yellow, and green triage patients, both adult and pediatric. Hospitals then report their capabilities in a web-based computer program called EM Resource that is kept up to date in real time. The RMCC reports back to the EMS scene with the number of patients that each hospital can accept, red, yellow, and green, pediatric, and adult. So, to make it simpler, RMCC does the busy work of communicating with all the regional hospitals for you. This frees you up to accomplish other incident priorities. The Regional Medical Coordinating Center, or RMCC, should be activated when you have 5 or more patients that will require hospital transport. Now, this may be from a confined scene such as a motor vehicle crash at an intersection, or an expanded scene such as a tornado strike in a residential neighborhood. When information has been gathered that there will be 5 or more patients, activate the RMCC to assist you in managing your scene. Why 5? Now, this number is flexible, but one that most of our pilot and test agencies have identified as a reasonable trigger. If, for example, you're in a rural community with a small critical access hospital as your only transport option, you may choose to activate RMCC for less than 5 patients. We discussed the number 5, and when 5 or more patients are identified as needing hospital transport, that RMCC should be activated. It is vitally important that RMCC be activated as soon as possible. It takes time for each hospital to report their capabilities. So, RMCC should be activated as soon as 5 patients are expected. This might be from dispatch call taker information, or from law enforcement that arrives on scene prior to EMS. As soon as you hear of 5 or more, don't wait, activate. You certainly do not have to be on scene and have physically assessed each patient prior to making the activation. And if RMCC is activated and it turns out that it is not needed, say the call taker information was quite inaccurate, it's no problem. You can cancel RMCC at any time with no consequences. By now, you surely have a burning question in your mind. How do I activate RMCC? The RMCC for our region is UW Hospital in Madison. They have received special equipment and training to fulfill this role. So to activate RMCC, you will call the UWER phone number 608-262-2398. When they answer, state that you are activating Regional Medical Coordinating Center. Stay on the line and provide as much information as possible. Now, in the relatively rare event that phone communication is not possible, say there's no cell coverage, the cell system's down, or you don't have a phone available, the backup is to use the SCWIHERC RD5 frequency. Call out to UW Hospital and inform the nurse on the radio that you are activating the Regional Medical Coordinating Center and that you are unable to use a telephone. You may be wondering how the RMCC is more efficient in calling each hospital than you would be from the scene. A valid question. RMCC uses a special web-based software called EM Resource. When RMCC is activated by EMS, the RMCC in turn alerts all regional hospitals via computer alerting system and text alerting system. Each hospital enters their capability to accept patients in the web-based system. RMCC reports these numbers back to the EMS field once they're obtained. Hospitals update this system in real time during an MBI incident to maintain accurate capability reporting. This is what the EM resource screen looks like for hospitals. They use this daily to update their capabilities and bed availabilities. When there's an MCI, they will get a specific request for red, yellow, and green capabilities. They will receive this notification in multiple ways, such as text, email, and an alarm in the emergency department. The ED factors in many items, such as transfers en route, 911 patients en route, waiting room status, ICU status, staffing levels. It will take them about 10 minutes to determine their capabilities. Let's dive a little deeper into your actual communications with the RMCC. You've identified that 5 or more patients will need hospital transport, so you decide to activate the RMCC. You call the RMCC number 608-262-2398 and state, "I am activating Regional Medical Coordinating Center." Try to paint a picture of what you have: location, type of incident, number of patients, and nature of injuries or illness. If possible, relay any pertinent information such as pediatrics, elderly, burns, inhalation, trauma, and hazmat. The EM Resources event will be updated with all the relevant information from the scene, and the RMCC will post any updates you give from the field. Do your best to keep ongoing communication with the RMCC to keep them updated, so they can in turn update the regional hospitals. If the incident is prolonged or involves large numbers of patients, don't be afraid to ask RMCC for updated counts. Patients may have self-presented to hospitals and affect their ability to take the number they originally said they could. The RMCC will generally plan to ask for updated counts about every 30 minutes, unless you tell them differently. It will be the decision of the transportation group supervisor to determine where each patient goes. RMCC does not tell you where to transport patients, only what each hospital is able to accept. This prevents one hospital from being favored over another. When possible, follow the Wisconsin Trauma Field Triage Guidelines to help guide your decision making. Use your critical decision-making skills like you do every day in EMS. You know that burns, if possible, go to UW. Bad trauma to a level 1 or 2 trauma center if within 30 minutes transport time. Really sick kids should go to UW, and minor kids can go to any hospital. Orthopedic injuries can be taken anywhere. The overall goal is to distribute patients for the best possible patient care and not overwhelming any one facility. Make decisions and go with your decisions. If you have too many cooks in the kitchen, there will be too many opinions, and patient transport will become delayed. We cannot emphasize enough the need to assign a scribe to assist the transportation group supervisor. There will be many things to coordinate and document, to view and to track. Having a scribe is vital to the success of the incident. The transportation group supervisor will be overwhelmed with radio, phone, and face-to-face communications. The scribe will allow for documentation of these important communications so that the transportation group supervisor can maintain organization and control and make potentially life-saving transportation decisions. Remember, the goal is to get the priority patients transported as quickly as possible to appropriate facilities without overwhelming any one facility. As the transportation group supervisor assigns patients to be transported to a specific hospital, he or she must update RMCC. For example, RMCC from transportation group supervisor, I'm sending 2 red to County Hospital, 1 yellow to Acme Hospital. The regional hospitals will be anxiously awaiting word that all patients have been transported from the scene. Once you have transported all patients, notify the RMCC and ask them for a count of total patients in each category for each hospital. Once numbers have been verified and they match the numbers from the scene transport log, notify RMCC that they can close the incident. Okay, you are now up to speed with SALT Triage, Triage Ribbon Kits, and you've been introduced to Regional Medical Coordination Center. But are you ready for the multi-victim incident? To best prepare, you must train regularly and frequently with these tools so that you can maintain proficiency. You may only have to use these tools once in your career, so it's your job to make sure that you are ready year after year. This concludes this training presentation on SALT Triage, Triage Ribbon Kits, and Regional Medical Coordination Center. We hope you embrace these as tools that will make a significant positive impact in your multi-victim incident scene management. Should you have any questions regarding SALT Triage, Triage Ribbon Kits, or general MCI, MVI incident management, please reach out to your South Central RTAC coordinator, Dan Williams. And should you have any questions regarding RMCC, please reach out to the South Central HERC coordinator, Jennifer Benke. An important note, please reach out to Dan or Jennifer prior to an MVI incident, not during the moment, as they are not available 24/7. Thank you very much for your time and attention to this session. And please remember that hands-on training is what has the most impact, so please train early and often with these tools to be proficient.